Chapter 17, Communication and Documentation. Communication systems and radio communication vital to response, on-scene communication, and delivery back to the hospital. So let's explore the different components. Different components of the system include the base station, a larger radio that sits at a fixed location. Mobile radios are the ones that are mounted inside vehicles. Portable radios would be the one that you carry on your person. Repeaters take the signal transmitted from any radio and boost it up to a power that can be heard all across your service area. Vital in urban areas where you have buildings that block things, and then also you have rural areas where you have long distances to transmit. So the repeaters are very valuable. Cell phones are an excellent tool now that we're using all the time to communicate back and forth at the hospital. We're actually using the data stream on them more to send information back and forth to hospitals through different programs there. And then the final thing we have is telemetry. It's transmitting the data from your cardiac monitor to the hospital. Typically done with cellular technology, but it's a different type of system there. As we embrace the new technology, we have computers and tablets we're using to send information back and forth to the hospital. Our data record keeping system in our region here is all computer based, so we can enter information into the patient care reports, and it's transmitted directly into the patient care reports system within the hospital. So we're moving data that follows the patient rapidly there. Most radio systems have a backup process. We have radios, 800 megahertz radios in our region. We also have VHF and UHF, a couple different radio frequencies there. On the disaster style system, we have the ham radios, the amateur radio operators, and then we always have our pager systems, which we still use for dispatching. Here's a representation of what the radio systems look like. So you've got your portable radio here. It sends a signal that catches a repeater. The repeater turns around and transmits it to other repeaters that can in turn transmit it back to the portable radios, to base stations, to ambulances, to the mobile units. Our radio system, the Pikes Peak Regional Communication Network, has 13 repeaters throughout the county, actually the two-county area, through El Paso County and Teller County. Have 13 repeaters, and they have 2 mobile repeaters that can be moved around as needed if there's any change in the system that they have, maybe a repeater system's down or something changes in our needs. All radio communication is monitored and regulated by the Federal Communication Commission. They assign who can get what license, what frequencies can be used by which agencies. They try to keep certain channels free for emergency traffic. Years ago, we had about 100-mile range on our radios, and so they would set a new every 150 miles you could have reuse the same frequencies, and occasionally we would pick up radio traffic from either Kansas City or Tulsa, Oklahoma, because of the way it bounced off the clouds and stuff. But now with digital technology, you don't have that issue. The other thing that you have to remember is they don't regularly monitor your radio frequencies, but they can, and they will investigate if somebody complains. So do not use any foul language, anything offensive. Even if your ambulance is on fire and you're bailing out, do not make a comment about the quality of ambulance you're being given to drive. It will cost a fine to your company and possibly give you some time to think about what you said. This should be in your book, rules to follow when you're using your radio system. Make sure it's turned on. That's probably one of the key things there. When you push the button, the PTT button, the press to talk, you hold it for 1 to 2 seconds. Wait till it makes a noise that says it's connected to the repeater system, and then you go ahead and talk. Do not put the microphone right up next to your mouth. Do not hold it too far away. You want it within a couple of inches of your mouth. When you call somebody on the radio, it's hey you, it's me. So hospital 1, this is ambulance 2. Hospital 1, this is ambulance 2. Um, use plain English. We do not use 10 codes anymore. Got rid of that. Um, unless your system does. There's actually some services that still use it, but use plain English. You don't have to be very formal. And then just remember, say things that people understand. Please, thank you, you're welcome. They don't have to do it. Uh, everybody understands that's what you're saying. Negative, affirmative instead of yes or no. Uh, spell out your words or numbers 1 5 or say 15 1 5. So that way people don't get confused on what you're saying. And do not use slang or abbreviations. Don't call into a radio and says I'm transporting a patient that's CCF, CCP, cuckoo for Cocoa Puffs. Probably not appropriate. When 911 gets the phone call, they get the information into the computer system, and the dispatcher will transmit it over the radio to you. Radio, sometimes pager, sometimes the computer-based terminal in your ambulance or your fire truck. You might get multiple resource or multiple communication methods, just so we have a good, concise message that everybody gets. Everything's done on a 24-hour clock, so if you're not used to it, you need to start getting used to the 24-hour clock. What we're looking for are the time the call came in, the time you were dispatched, the time you arrived at the staging area or on scene. The dispatcher will tell you the times when you say that you're en route or on scene, or you use the mobile data terminal in your computer in your ambulance. These are documented because many services have response time standards that you have to maintain, or they're a violation of contract with probably fines associated. So that's why you hear ambulance concerned about response times. Plus, the longer you take to get to the scene, the more damage a patient could have. So very important to document all that. When you're talking back and forth to dispatch, just another thing is remember that's all recorded. So a lot of your ambulances have a mobile data terminal MDTs. When you get on scene, you press a button that says on scene. When you transport, you press a button that says transport. It's important to use all the communications methods possible so that we can document where you were, how long it took you to get there. All ambulances also have GPS, so if you forget to push the button, we can look at the record of the GPS on your unit and find out how long it took you to get there, and document all that process too. So we've got a backup system, but use the primary system. If you get out of the ambulance or out of your vehicle, make sure you have a portable radio. That's your lifeline to call for help. On the top of all radios is a big orange button. We call it Bob. If you hit Bob, that sends an emergency signal to dispatch. All other frequencies shut down, and they pay attention just to you until you say you're okay still. So that's your emergency button there. B-O-B, Bob. When you're going to the hospital, you need to give them a report on the radio, in person, in writing. They need to know what's happening with your patient. We typically give a radio report, gives them a brief idea of what's going on with your patient. Rampart, we're coming in with a 25-year-old male patient and an MVA, driver of the car, T-boned on the driver's side, multiple 18-inch intrusion into the passenger compartment, multiple injuries, vital signs are stable, and we'll be there in 5 minutes. So simple information, just give them a little picture so they know what kind of patient they're dealing with. Some systems allow the EMS crews to say, I've got a trauma alert, a cardiac alert, stroke alert. Know what your system allows, and you make those calls. It kind of depends on how much trust they give to the EMS in your area, but you want to give them that good idea. There are times that they do listen and sometimes they don't. I had a cardiac arrest one time I was bringing in. I could tell the nurse wasn't really paying attention to the fact that I said CPR was in progress, because she got to the point on her chart and it said enter vitals, and so she asked me what my vitals were. So I gave her a blood pressure of 0/0, pulse of 100 beats a minute, respirations 2 times every 30 compressions. And she got kind of embarrassed and upset at me, but that's okay. Given the report, talking over the radio, noticed that the EMT is wearing his seatbelt while he's in the back of the ambulance. Very important accessory to make you look cool. He's got his laptop there, or his iPad, holding that in so he can document the stuff. He's calling the hospital by the phone. So we got lots of options there. The good thing about radios and phones into the hospital, both of them are recorded. So if someone says, I didn't tell them to do that, or I didn't hear them say that, you've got a record keeping that you can go back and look at and listen to see if they actually said it. El Paso County has a specific radio report process I will pass out to you in class. Important things you need to identify is who you are, what unit are you on, and what's your level of service. Are you a BLS, ALS? Let them know. The ETA, estimated time of arrival. When you say ETA, that's a number of minutes. You do not have to say my estimated ETA is about. That's 3 different ways to say estimated. Estimated time of arrival is at about approximately 5 minutes. Just say ETA 5 minutes. Patient age and biological gender. If they have a gender preference outside of their biological status, you can identify that in this call. Chief complaint, brief history, maybe some pertinent medical history. They had a heart attack 2 years ago and now they're having chest pain. That's important. Anything major in their past. One thing you do not see on this list is the patient's name. We do not transmit that over the radio, over the phone. Over the phone would probably be okay. Over the radio, because other people can tune into those frequencies, and we don't want to give the personal medical information over because that violates HIPAA. You also want to include the mental status, baseline vitals, any pertinent findings in the physical exam or pertinent negatives in the physical exam. What's your basic care that you were given? You do not have to say, I placed the patient on the EKG if you told them what the EKG is. Or you do not have to say, I put them on a pulse ox and the pulse ox is. Only say what's important. And it takes practice and skill, and you will say more or less each time until you get down to a rhythm that's appropriate for you. If they had any significant changes to your care, document that. If you are going to ask for medical direction, state that at the very beginning, because they'll need to get the doctor there close enough to hear the call so you don't have to repeat everything. When they do give you orders, repeat them back. Repeat everything that they said back to them and confirm it. If you're not sure what they said or something doesn't make sense, question it. If they ask you to do something that you can't do because you're not the ALS provider and they say go ahead and give them a 50 milligrams of beryllium and that's not on your list, do not give it. Ask them, tell them, hey doc, I'm a basic BLS unit here. I don't have access to that. So the verbal report, once you get to the hospital, you got to talk to the healthcare providers and tell them what's going on with your patient. I always started off by introducing the patient to the staff. Mr. Jones, this is Dr. Bronski. He's going to be the one taken care of. Here's Nurse Ratchet. She's going to be your nurse today. Here's what happened. Mr. Jones said he was having some chest pain this morning. It never got better. After 2 hours, he called 911. This is what we found. This is what we've done. This is his vital signs. And anything else you can think of to tell him. It's a little bit more than what you did over the radio because you're in person. They will ask you questions. You will clarify the questions. When they are done, you can take off and go get your ambulance back in service. But don't just drop your patient off without giving some type of report in a normal situation. There are times that we're going to skip the verbal report because of mass casualty stuff, but that's a totally separate process, and it's not part of our normal everyday operation. Things you want to make sure you include is the chief complaint, history, assessment, any treatments, and any vital signs you took. Because your vital signs on your patient or your radio report are usually just a one-shot thing, so you're going to give them the whole information. Vitals, the blood pressure's been going up, pulse has been going down. All right, little interpersonal communication. If you don't like talking to people, you might want to have a career change option here besides EMT. As an EMT, you're going to be part of a huge system of healthcare that's going to require you to talk to all kinds of other responders and healthcare providers throughout the continuity of care of your patient. Other first responders, EMTs, paramedics, home health care, family, doctors, nurses, everybody you can think of. When you're talking, show respect. Know when to use authority and when to sit back and listen and let the person vent to you. So it takes practice, but again, it's going to come to you as we go through the process. Therapeutic communication is talking about how we talk to our patients. What we want to do is get to the point where we can ask the questions that we need to and get the answer that we're looking for. So it's just a way of making people trust you and get comfortable in that first 5 seconds so that they'll tell you everything they can about them so you can help make some better decisions for their health care. Use eye contact. If you're wearing sunglasses, even if you're outside, take them off while you're talking to your patient. Eye-to-eye contact is important. Keep your face at the eye level and your arms down to your side. Do not stand with your arms crossed in front of you. That's a closed body posture. Have an open body posture. For safety purposes, you're going to stay back a foot or two, but you want to be down on their level so that they can have good open communication with you. Notice the EMT is down on the level of the patient, talking to her, holding her hand, making her feel comfortable, trying to get her to relax. And part of the time, getting the patient to relax will help them medically too, besides being more comfortable to tell you what they need. Use the language the patient understands. Kind of gauge with what you're talking about with them, what they know. They may know more medical terms. They may answer your questions in terms that you don't know because they are more in tune with their disease process. So ask questions. Tell them what you're doing and why you're doing it. That's part of good patient care. The other thing is you need to be honest with your patient. Now sometimes you can be completely honest, and sometimes you have to avoid the answer. If you have two patients in a car crash, one of them is obviously dead, and the other one says, "How's my partner doing?" Do you want to be completely honest? Probably not. What you want to do is say, "Hey, my partner or the other ambulance is taking care of your friend. Let me focus on you right now." So you can be honest, but just not completely honest, because you don't want to destroy what you're building with your patient. You don't want to upset them if you don't have to. Use their name. Honey, babe, sweetheart, probably not the best options unless that's the style in your part of the country. But you want to get their name. Ask them what they prefer to be called. If you walk up to your patient, "Hey, I'm Ken. I'm with EMS. I'm here to help you." And I say, "What's your name?" They say, "Sergeant Major Plumley." I said, "Okay, what can I call you?" "Sergeant Major." "All right, Sergeant Major, thank you." That's how they want to be addressed. If they say, "My name's Bill, but I like to be called Bill," that's perfectly fine too. So listen to them. When you ask a question, listen for the answer. Listen to what else they tell you. If they give you an answer outside the order that you're thinking you wanted, don't ask the question again. Remember that they told you once. I always like to go into McDonald's when I'm ordering. I say, "This is to go." I give them the order. They pick the pictures out on the screen. place the order, and then they look up at me and says, "Is this for here to go?" I just said I was to go. Listen to me, people. Sometimes you have to take their mask off so you can hear them. Sometimes you have to wait a little bit to kind of give them time to answer you. Sometimes they may have communication problems. They can't speak to you the way you think. So you might have to be creative. Maybe get a notepad out and have them write their answers, or you write the questions on the notepad so they can read them if they can't hear. So there's lots of options, and we're going to practice all these throughout the class, but it's something you really need to get in tune with, is trying to communicate with your patients. And those were the special considerations. Some people have trouble communicating, so you try to get on their level, work with them, maybe use some visual or hearing impairment tools. Maybe they have a language barrier. If you know the main languages in your service area, that might be helpful. A friend of mine, she was one of my students years ago, went to work for Acadia Ambulance down in Louisiana. She had to learn to speak Cajun because that was just the backwoods language everybody was speaking, and it didn't quite make sense in English. So know your primary languages. Pediatrics, always be truthful. If it's going to hurt them, tell them it's going to hurt them. Work on their level. That's physically, mentally, emotionally, not emotionally, sorry. You want to be on their level so that they understand you and so that you're actually getting good communication. Maybe show an example with one of their toys or their dolls. Hey, I'm going to put your doll on oxygen. Now I'm going to put it on you. I'm going to start an IV on your mom. Now I'm going to start one on you. Would you like to poke me with the stethoscope before I poke you with it? Okay, patient care reports, the next level of communication, the written. If it wasn't written down, it never happened. It's kind of like going to the outhouse. It's never done until the paperwork's completely done. So we have several forms here. We have handwritten, laptop, tablet, pen-based computers. The majority of our documentation now is based on laptop and sometimes tablet. Pen-based disappeared. That was your Palm Pilots back in the 90s. Drop transport report. This is that quick little documentation you may have from a fire first responder to the EMS crew. Something just to give them the basics so they can move on. But always have handwritten notes in the background, just in case the computer system goes down, in case you can't find the computer, you lose your computer, that's even worse. But always have the ability to do handwritten notes. Things you're putting in your patient care report. Document the findings and treatments. Everything you found, everything you treated, what they did when they treated. You're going to draw a picture of the scene. You can either draw a map of the scene, you can draw pictures of the cars, you can use your words to paint a picture of the cars. Paint a picture of the mechanism of injury, whatever happened. This paperwork that you create goes into their patient care report at the hospital and follows their medical record throughout their whole treatment. So it's not just for you, it's for the doctor in the ER, it's the trauma surgeon, it's the physical therapist. It's everybody along the way is going to look for your medical report as part of the record so they can figure out what happened to start this whole process. It's also a legal document. It can be subpoenaed and used as evidence. When I worked for Springs Fire, I got subpoenas multiple times a week for medical records, and I had to take them to court and provide them for the evidence. So a lot of times they were just looking for information to use for some other purpose, not specifically as a case against the EMS providers. But it was like a he said, she said, and this helped out. They can also be used, like we showed in that trial video, as a method to prove or disprove what you did as an EMS provider. So write down everything you did, everything you can think of, and make sure it's all documented because you never know when it's going to come back. We also use it for insurance information. We like to get paid as EMS providers. Our services gain money by billing the patient, their insurance, or the government for their health care. So it's important to get the information. When I would do audits of the medical records for the fire department, I found out that we had a huge population of John Does in our community. And what we were finding were people were just forgetting to get the name or the address of the patient and just writing in John Doe. It became an issue not for billing purposes, but for just providing the right document to subpoenas and requests. If I was working for an ambulance service and we were billing patients, the right name and information would be critical to getting that collection, to getting the money back for the treatment we provided. We also use it for clinical research, statistics, continuing education, making sure you're having the skills that you're supposed to. If you've been an EMT for a year and you haven't started one IV, that might be something we need to track and identify as something we need to improve for you. Maybe you need to go back and do some practice sticks just in case, just to keep you up to speed. Part of the quality assurance, quality improvement process, we look at these run cases to see if there's ways we can improve our medical care in general. How many patients got taken to which hospital? Why were they taken to which hospital? What was done to treat them on the way to the hospital? Maybe we haven't used this device in 2 years, and do we even need to have a backboard? So those are things we're going to look at through our quality improvement process based on your patient care reports. So key things you're going to have in the report. These are required by the National Highway Transportation Safety Administration, NISTA. They have 400 different data points that they're looking at to try to develop national statistics, like how many crashes are there, how many crashes are caused by drinking and driving, how many crashes are caused by marijuana and driving, texting and driving, how many of the patients in the passenger seat are hurt versus the patients that are in the driver's seat. They're looking at all different elements to try to develop national trends where they can focus their attention. So part of the information they're looking for is the name of the agency, all the date, time, who responded, what levels, everything about the service. All the times based on the dispatch. So you don't just make up your own times when you get there and when you left the scene, because they're curious. How long is it taking for our EMS crews to get to the scenes, and how long does it take to get to the hospitals? Patient information, all the key demographics, the name, address, phone number, age, gender, date of birth, weight, race, billing information. All this information they'll use for data information. Now, this portion here, the narrative of the report, is going to look kind of familiar. It kind of sounds like our assessment process. What's your general impression? What's your mechanism of injury or nature of illness? What's your sample history? What's your OPQRST? What are your vitals, procedures? What's your assessment look like? Transport. How did you transport? Did you transport emergency or non-emergency? Where did you take them? Did you take them to the most appropriate facility? Did you take them to the hospital of choice? Did you take them to one hospital because the other one told you they were on divert? It's all important information. If you have an insurance that says we only allow you to use in-network ER services, and that would be Centura, and you take the person to UC Health, they're going to want to say, the patient's going to want to say, I didn't have a choice. That's what the EMS crew took me. And if you put this in there, the patient requested, then the insurance has something to stand on. If you say the patient was unresponsive and we went to the trauma center, then that'll support the patient's rights. Narrative section, you're looking for subjective, objective information. Document everything you can. Sometimes we document what they say, but make sure you put it in quotation marks. That way they know that that was the opinion of the patient. Do not put your opinions in here. Don't say, I think the patient was abusing drugs. All you do is say patient had multiple track marks on the arm and a bottle of heroin in his pocket. You don't say they were using it. You just say what you find. Chief complaints, pertinent negatives. If you expect them to have pain in the job, but they didn't when they're having their chest pain, document it. That's what we want to have written in here. Narratives of you don't use radio codes or non-standard abbreviations. Don't make up your own. That's why the SOB is probably not the best one to throw in here. Just write dyspnea. The other thing is, because of our great option to use computer-based reports, we have spell check, so we don't have to worry about our writing not be legible. The one warning I have for spell checking on your computers is if the computer says it's wrong, don't think you know more than the computer and hit add to dictionary. I had a monthly appointment on my calendar for the fire department to go in and delete all 50 spellings of appendectomy that were incorrect. Every month I had to go through and delete probably 400 words that people added to the dictionary because they were spelled wrong. One key thing to remember is if it's not written down, you didn't do it. And that was the example that was showed in that Cobb County trial. Alright, some special documentation issues you're going to run across. Remember, everything's covered by HIPAA. You need to make sure you don't just leave your medical reports laying anywhere. They go with the patient's chart. If they're printed off electronically, they go right to the patient's chart. Either way, make sure they're there. If you're not covered by HIPAA, if your service doesn't transport, you're still covered by the Colorado Open Records Act, which has a confidentiality clause, and it actually has jail time for you versus HIPAA, which just has fines. So make sure everything's secured as far as your confidentiality there. If the patient is refusing care, you think they need to go to the hospital, but they decide they don't want to for whatever reason, you need to be very careful about how you document it. Document what you told the patient to try to convince them to go. Document that you called into medical control and let the doctor talk to them. Document that they understand the consequences. Document them that who's staying with them and that you told them to call 911 if anything changes. If you have a specific refusal form, make sure that's signed by the patient. Make sure that I always like to have them write out the consequences on my form, just so I know they understood it enough to write it down. If you make an error, document what you did. Don't try to cover them up. If you cover them up, that gets you in more trouble than just saying I made a mistake. If you forgot to do something, document that you didn't do it. If you're making corrections in your handwritten reports, do not just scratch over it and black it out completely. It's like a government report. If you get it and there's a bunch of redacted areas, you're going to wonder what the redacted part says. Just put a line through it, put your initials on it, and go on. We all make mistakes. We can correct them super easy like that. If you remember something after the report's been turned in, make sure you document that the changes and when you made the changes. That's something important they're going to want to know when they do the final reading of the reports. Mass casualties incidents. If you have more patients than you can hand, that changes our process of documentation. We'll get to that when we cover the mass casualty chapter later in the class. But you don't have to document a patient care report for every patient. It's very simple. You document a chief complaint, maybe a set of vitals or two, and then they have a person called a transport officer that does all the communication to the hospital and documents all the paperwork for all the patients. So it's a really compact process that we've made to make it easier for us to get the patient to the right place at the right time. Other things we might want to report or have special documentation. If you get exposed to an infectious disease, you need to document that with your service on whatever forms they make available to you. That way, if in the future, if you do contract the disease, there's a written document that shows when you caught it. If you get hurt at work, document it. If somebody else gets hurt at work, you need to document it just so that when they come back for a workers' comp claim, everybody knows what happened and we've got it done. If you go into an unsafe scene, inadvertently, you don't know it's there, document what you found and how you handled it. If you get a patient that needs more than you can handle, more than EMS can handle, maybe they need some social services, document that referral. Document that you referred them to the 211 system or Catholic Charities or uh, Cedar Springs or whatever the systems are that has some options there. Colorado, it is mandatory for EMS providers to report abuse, child and elderly abuse. It used to not be. They left EMS out of the law, so fire, police, hospital systems, they all had to report, and EMS did not have to report. It's been changed over the last several years, so now you report it. It's as simple as telling the doctor when you get to the hospital, hey doc, I suspect based on this that there's something that needs to be investigated. You don't have to know who did it. You don't have to know what exactly happened. Just say, hey doc, something's not right. You need to check into this. The other thing that helps is we always dispatch law enforcement with EMS when we get any patient 10 or younger, or over like 65, we send an officer if we can, just so they're in there and they can see what's going on and be there to receive the reports almost automatically. And with all, as always, with all our classes here, if you have questions, write them down, bring them to class, and we'll talk about them. Thanks and have a great night.